infection with you people. I think many of you know about this topic. It's not complicated. I try to simplify the things and also to have some updates that we are going to see together today. So to follow the topic, I did this plan. After a short definition, we're going to see the etiology of this infection, the cause of this infection, and the third chapter, that's going to be the classification to see how we can classify, because the classification has a capital role for the treatment of the urinary tract infection. Then we are going to see together the clinical features, diagnostic, the differential diagnostic, treatment, complication, the prevention. So at the end, there's going to be a short chapter, some clinical cases that we can work together to see if you got something from a presentation. Of course, the urinary tract infection or the infection of the bladder, urethra, ureters, and kidney that are most commonly caused by bacteria. It could be also by virus, fungi, other bacteria is most common. So the most frequent bacteria which is the responsible of this infection is E. coli or Escherichia coli. At the same time, we have lower urinary infection. It's very common in the clinic and hospital. When a patient comes to the doctor, between us or in rapport, we talk about lower or upper infection. So the lower infection is the infection of the bladder and urethra, and the upper infection, they're the infection of ureters and kidney. It's also important to know, like a small definition, that the women have higher risk of contraction of this infection than men, because of a shorter urethra, and secondly, the anus is close to the urinary tract, so we call the migration infection. Other risk factor of this infection is the sexual intercourse involving urinary catheter by hospitalized patient, pregnancy, of course, and abnormality of the urinary tract. So the abnormality could be anatomical or physiological. Now we have uncomplicated and complicated infection. So the non-pregnant people, the premenopausal women, are considered as uncomplicated infection. Unfortunately, for men or individual with the high risk factor for treatment failure or serious outcomes, and at the same time, a recidivate of the infection or functional or anatomical abnormality for the urinary tract, they're considered like a complicated infection. When this kind of patient come at the hospital, so we have to take them seriously in charge. The clinical finding depend on which part of the urinary tract is affected. So as simplified here, we see this is the urinary tract, and this is the urinary tract system, which is composed from kidney, both of them, right and left kidney, ureter, bladder, and urethra. So the lower infection, that means the bladder and the urethra, as we're seeing here, most of time the patient have dysuria, suprapubic pain, or sometimes left or right, back abdomen pain, urinary urgency, and frequent urination. For the upper urinary tract infection, we have these signs and symptoms plus fever and flank pain. So in literature, we say that the bladder or urethra infection, they are never accompanied by fever. So when the patient comes with fever or flank pain, we have to know that it is a complicated infection, or a ascended infection. The cause of this infection, as I said at the beginning in the definition, they are pathogens, and at the same time, we have predisposing factors. So the pathogens, they are the bacteria, most common, And they are the essence or association of the bacteria. And here we have a short key to remember always these 5 bacteria. Sec P, P. PP in French, it means urine. Sec, we know sec. We don't write sec like this, but it means not normal PP. What is the sec PP? S is for saprophyte, Staphylococcus. A is for E. coli. The other E is for Enterococcus. K is for Klebsiella. P is for Proteus, and the other P is Pseudomonas. We have these 5 bacteria which are most common responsible of the urinary infection. We can also see virus infection, but they are very rare. We see most of the time by immunocompressed patient or children. And the virus could be adenovirus, cytomegalovirus, Beka virus. I don't know if some of you heard about Beka virus. Beka, I don't know exactly when it was discovered. So this was the first time that they discovered this virus in the urine of a patient. His name was, I forgot, but the acronym of his name was Beka. So they called this virus on his name. Fungi, they are the yeast, very, very rare, but they could also be the cause of the infection, the urinary infection. So what is also very important to see or to know that for the upper urinary tract infection, 99% they are the bacteria which are responsible. The virus and fungi, they infect the ureter and bladder, but they cannot do the ascension to the kidney. If my Vetis is quick, if I'm going quick, you can also stop me, please. If you have any question, you can also stop me here right now or at the end of the chapter. Please write your questions. How is the pathogenicity? Is important also to know, as you see in this picture. Here is the rectum and the anus. Let me make a zoom out. And they took like best example, the Escherichia coli. The bacteria is in this region, in anus, so the bacteria move. The first move is to come in vagina tractus and at the same time in the ureter. And here is the ascension of the bacteria. The bacteria come and colonize the bladder. And after, here is the chemical mechanism between bacteria and the receptor of the mucus of the bladder or the wall of the bladder. And then the bacteria goes inside and start the activity. I think we can move. The predisposing factor. We have 3 types. First is host dependent. It could be a structural or functional abnormality. So a patient with abnormality from birth, they have high risk of infection. Or it could be the new abnormality. It means that the patient was healthy, but with time developed some clinical issues like benign or benign prostatic hyperplasia, congenital malformation, urinary bladder diverticulum, and urinary tract calculi or neurogenic bladder. These people, they have a high risk of the urinary infection. The sex also play an important role. Female individual, as I said at the first of this topic, they have a high risk of infection. And male individual, they have high risk of infection, especially by uncircumcised male infant. So in Farsi, they said sunat, the people who are not circumcised, if they get infection, it will be complicated, and they have also a high risk of infection. Pregnancy, because of hormonal charge during pregnancy, they have also a risk of infection. Or postmenopausal, because of reducing or decrease of estrogen, which is the hormone. So they have the lactobacillus, the diminution of lactobacillus, and the pH is increasing, so the colonization by bacteria is also high. The other predisposing factors, unfortunately, is prior condition. The previous urinary tract infection, history of kidney surgery, immunosuppression, diabetes mellitus. This is also a part that I'm going to see with you maybe next week, I think. Sexual intercourse, post-coital cystis, and some contraception that the woman use, like spermicides, diaphragm, and also at the hospital, there are the nosocomial urinary tract infection or catheter-associated tract infection. Here we have this picture. I don't know if the quality is good. The disease of the urinary tract. They could be at the same time the risk factor for infection. So as we see here, the prostatic hyperplasia, unfortunately, disturb the evacuation of the urine. So you will have the stase of urine in bladder. It could cause the infection of bladder, so like cystitis, or urethra here is also, as we see, the anatomical form is not normal, so there is a retrocessment. This is also, unfortunately, a factor. So diverticulum and bladder that we're seeing here, one in right and the other in left one. We have the ureter malformation, and in kidney we have calculus or stone, dilatation of calculus, and at the same time we see here some cyst and pemphigus. And here also, like simple schema, we have the normal prostate, and here, unfortunately, the cancer of prostate or the hyperplasia of the prostatis. This is the first high factor risk in men. And here we see also the abnormality of the urinary tract, the upper urinary tract. Now, we are in the classification. As I said at the beginning, that the classification is very important for the therapy of the urinary tract infection. And this classification, so in practice, we use all of them, but most of the time, this to site of infection and the type of infection. So in the classification, we have level of complexity, uncomplicated and complicated. If you remember, I said pregnant women, men, and people with high risk factor, they could have a complicated infection. The site of infection is the lower tract infection that we saw, an upper tract infection. So type of infection, is it acute infection or chronic? In some definition, they say that if it's less than 4 weeks, so this is acute infection, more than 4 weeks or month, it is the chronic infection. There is one other classification that we don't have here, is to see if it is the right recidive infection or it is the resistance infection. And based on the symptoms, we have asymptomatic and symptomatic that we see in next chapter. The clinical features, the symptom or clinical feature of lower urinary tract infection, as you know, we saw at the first page of this presentation, it is the irritative lower urinary tract symptom, increased urinary frequency or urinary urgency, dysuria, hematuria, suprapubic tenderness. The hematuria, it could be also microscopical or macroscopical. So the patient come and they say, okay, I saw that the urine or raw, or sometimes we discover this in laboratory. At the same time, for the upper urinary tract infection, which is very, very complicated, that we have to take in charge immediately the patient, we have to treat this, is the pyelonephritis, or the infection of the kidney. They share the same symptoms of lower UTI, plus fever, flank pain, costovertebral angle tenderness, fatigue, malaise, nausea, and vomiting. Sometimes the patient, unfortunately, also cannot talk. We think that they have some psychiatric issue, but they have a big pain that they are not able also to talk. We could also have some other signs, like by men, the pain is in prostatic or perianal area. Children, we don't have time to develop it here. They cry a lot, and they cannot stop to crying. And when we touch the abdomen, they have a big pain. And unfortunately, the fever is also sometimes difficult to know by children. But in any case, if a children come with fever and cry, we have to see, this is the key word that we know at the hospital. We have to check the sore throat, abdomen, and the urinary tract. Or sometimes adults come with delirium, acute confusion. As I said, we don't know if the patient or in critical situation that we have to take in charge or not. But in any case, when the patient comes with fever and urinary infection symptoms, immediately we have to take it serious in charge. Here I wrote something in this color: in patient with fever and or flank pain, which are usually absent in lower urinary tract infection, consider a more serious infection, and it could be also pyelonephritis most common. Dysuria without urgency or frequency may suggest vaginitis or sexual transmitted urethritis rather than cystitis, especially if accompanied by abnormal vaginal or urethral discharge. This part is in practice, how we can confirm our diagnostic. Patient come with clinical signs. Most of the time, we don't need an emergency, especially in emergency, we don't need laboratory research or some radiologically examination to confirm our diagnosis. We could say clinically patient come with these 3-4 signs, and it's very clear we have to start the therapy. But here we see that this 4 topics is going to be easy for us. We have the uncomplicated lower UTI in women. They have the typical symptom. We have to start the therapy. If the symptoms are unclear, we can also do a urine analysis. The urine analysis or sticks. We take a little bit urine and we drop sticks, and we have to compare with our result. If this analysis is positive, we have to initiate the therapy. Which therapy we can see next chapter. If it's negative, but persisting suspicion, we have to obtain the urine culture. For complicated UTI in lower system in women, directly we have to obtain the urine culture. Urine culture, I don't know if you know how it works. We give a small bottle for patient, and we say they have to give us not the first, but the middle urine. They have to start urinate, block, and then they give us the metal part of the urine, and we see the culture. For lower UTI in men, directly we have to obtain urine analysis and urine culture. I hope it's clear. For uncomplicated, we can also, we do only the urine analysis. But if it's suspect, if it's not clear, we can also do the culture. For women with complicated signs, we have to do culture. It is, we have to do it, it's obligatory. And by men, urine analysis and urine culture. And also, sometimes we can do CT or use ultrasound of the urinary tract. Hello? Okay. And for upper UTI, the pyelonephritis, as I said, we could also treat, and most of the time it needs a serious therapy. We have to send the patient to the urologist. We can see the pyelonephritis maybe in next page. The diagnosis for urinary tract infection is not complicated. We have laboratory studies like urine analysis, culture, additional diagnosis. We have to also do the pregnancy test. A woman come and said, okay, I have the signs. We can do the urine culture analysis, but we have to also ask about the pregnancy issue because of the therapy. Some medicines or medication we are not able, we should not start by pregnant. We could also do the STD screening, also we call it. So they are the sexual transmitted infection, to see if there is an association between these two infections, or blood tests to at the same time to see if the patient they have diabetes or they have also the upper UTI, which need other therapy. We could also do CT, UTI, ultrasounds, so ultrasounds, a lot of other examination, but they are not needed in first line. If the patient, if we start the therapy and we see that the patient have a resistance, we could also see if there is also a complication or abnormality of urinary tract infection. The patient with first infection, we should not do that. If we try, and so like patient come and say that since 2 years I'm always having this problem. I took money therapy, but unfortunately I couldn't profit. We have to see if there is some abnormality. Great. So let's see the time. Okay, we have like 20 minutes. The differential diagnosis. Do you have any question till here? Okay, so no question, we are going to follow. The differential diagnosis. So in medicine, this is a nice and important part to see. Sometimes the patient come with the same signs and symptoms. We should not see directly the infection. At the same time, we have to see, okay, if it's not the urinary tract infection, what could it be? So this is good for doctors to have like a reflection. The patient come, most of the time we have many sickness and diseases. They have the same common signs, but they are not the same. They don't need the same therapy. They don't have the same church. They don't have the same prognosis. So that's why it's important to know the differential diagnosis by every pathology. It could be the interstitial cystitis. This is a painful bladder syndrome. We call it also like this. It is chronic non-infection cystitis, so they don't need any antibiotics. They're chronic, as I said. The patient most of the time they say, yeah, since 3 months I'm suffering from. And there we also cannot have a clear etiology for this infection. That is most frequent by women than men. The symptoms last more than 6 weeks, and the pain is suprapubic. And sometimes they don't have also this urine urgency or like the other signs of the urinary tract infection, the lower urinary tract infection. To do the diagnosis, to clarify the diagnosis for interstitial cystitis, we have to do, of course, urine analysis. Why urine analysis? Not to confirm the diagnosis of interstitial cystitis, but to confirm if it is the bladder infection or cystitis. Urodynamic testing to see if there is abnormality of anatomical structure, if there is a urine retention, or we can also refer to cystoscopy to see if there is some bladder cancer or ulcer or some any other inflammatory cases. The therapy is to avoid alcohol consumption, coffee, or we have to manage the stress. Bladder training, that here in Switzerland, they are the physiotherapist who could help the patient. The pain management with some medicines. Amitriptyline, if this is psychological medicines that we could give the patient to reduce their stress and to calm the patient, or sometimes the invasive procedure, that means like operation. The second differential diagnosis, this is the asymptomatic bacteriuria. So patient come at the hospital, they have no symptoms, we do the urine analysis and we find bacteria in the urine. And most common bacteria is the E. coli. This we find by all patients, so the age is more than 65. They have at the same time, unfortunately, other comorbidities like diabetes mellitus, spinal cord injury, so that this patient, they cannot also discharge their urine. Unfortunately, they have a urine retention or enveloping urethral catheter that the colleagues, maybe they can also confirm this. Unfortunately, at the hospital, we see many patients who had catheter, so they have also the infection. Or pregnancy, as I said, by pregnant women, we see unfortunately very frequent infection. Diagnosis, as always, urine analysis with microscopy, and the management is the treatment is recommended in individual signs and symptoms, and there is also some invasive therapy. It means the patient, we have to treat the risk factor of this patient. So diabetes, we have to manage diabetes, or instead of urethral catheter, we have to use cypripebis, punction. There are some management. The other differential diagnosis of vaginitis, the women have pain, but pain is not during urinating. Pelvic inflammatory disease, prostatitis, urethritis, tuberculosis, yes, also common, not here in my clinic where I am in Bern. I didn't see any patient with tuberculosis cystitis, but in other country, in Mexico, I saw many people. And drug-induced cystitis, hemorrhagic cystitis, some trauma or car accident, structural abnormality of the urethra, like diverticulitis, as I said, or other diseases of that bladder. My favorite part, the treatment of the urinary tract infection. If you remember at the first part, we saw the classification of the urinary tract infection, and I said that this classification is going to help us for the therapy to see how we can treat it. Here, we have the uncomplicated lower urinary tract infection, cystitis. And the bacteria which is most common responsible is the E. coli. We could also have the other 5 bacteria. You remember, CPP. The therapy is empiric antibiotics treatment of uncomplicated lower UTIs. Empiric antibiotics therapy, it means that before the identification of the bacteria, we start the therapy for the patient. And this therapy is the nitrofurantoin. This is an antibiotic. We give 2 times a day, like 200 milligram, 5 days per patient. So 100 milligram, let me make a zoom out. We give 100 milligram morning after meal and 100 milligram at evening. And at the same time, we have to also serve the patient. We counsel the patient to drink a lot of water to have the possibility to transport the maximal quantity of this bacteria in bladder. Plus symptomatic therapy and hygienic and dietary measure always. What is this hygienic and dietary measure? The patient have to go frequently to evacuate the urine. They have to wash after every sexual contact, the genital area, and better I said, during this 4 or 5 days that they're using antibiotics, they have to make a vaginal or genital shower after every time that they go to the toilet. And this is very individual, but I said to my patient also during the therapy, this 5 days of therapy, no contact with partner, no sexual contact. We have also for cystitis the alternative, which is the fosfomycin, or maybe in Afghanistan we have monoreal. This is only 1 tablet, 3 grams. We give per dose. So this is a quick and short therapy, which could have the same benefit as nitrofurantoin for 5 days. I didn't see in literature the benefit or better benefit on fosfomycin than nitrofurantoin, so we use both of them, and both of them have the same result of the therapy. The alternative is trimethrin plus or sulfamethotrexate, we call it in short TMP-SMX. We give 2 times per day for about 3 days. And amoxicillin and quamoxicillin, this is also the alternative if the patient is pregnant. So for the pregnancy, we're able to give quamoxicillin and amoxicillin. So I want to make a resume. This is not complicated. You have to keep in mind today after this lecture that we have the cystitis, which is the uncomplicated lower urinary tract infection. We give fosfomycin or nitrofurantoin. Fosfomycin, we give only 1 tablet, 3 grams, or nitrofurantoin, 200 milligram, 5 days, plus symptomatic therapy, and we have to say the patient how they have to care of their body and especially urinary tract. The complicated lower urinary infection. The antibiotic therapy must be adapted. So here is no empiric therapy. You know, here I said empiric therapy, empiric antibiotics, but here it should be adapted. What does it mean? It means that we have to do the urine culture. And in urine culture, we will have the responsible bacteria and at the same time, the study of the resistance. So we have to see which kind of antibiotics can we give, which is most good adapted for this bacteria. For a complicated cystitis with urine culture, we can give ciprofloxacin 2 times 500 milligrams, 7 days. In some books I wrote, I saw that they wrote 6 days. No, it's 7 days to avoid the resistance of the bacterial infection. The alternative is TMP-SMX or ceftriaxone, but ceftriaxone is intravenous. Most we use at the hospital. So, as I said, in pregnancy period, the only thing that we can give is coamoxicillin 3 times 625 milligram per oz 7 days. Or if the patient are hospitalized, we can also in pregnancy, we could start the first dose with ceftriaxone and coamoxicillin, but it's complicated. You have to forget it right now. And the urethritis, of course, that it is not the topic of today. But it's also a part of urinary infection because the urethritis, it could be part of urinary tract infection or a sexual disease or sexual transmitted disease infection. But if it is the urinary infection, we give ceftriaxone 500 milligram, the first injection intramuscular, or we give 1 gram intravenous. It's important to know when we give ceftriaxone intramuscular, it's 500 milligram. Intravenous is 1 gram. Once, and then we switch the therapy in pairs with doxycycline 2 times 100 milligram, like above that we say. 200 milligrams 7 days, and we have to adjust the therapy depending on laboratory findings. I hope it's clear. So the infection of upper urinary tract infection or pyelonephritis. I have a simplified picture or schema here. So the upper infection is most common or very, very frequent, which is pyelonephritis. So the pyelonephritis, like rhizome, the responsible bacteria is E. coli. We could also have in laboratory hematuria. The patient, they have very pain, big pain, and in flank. They could also have alteration of the general signs, vomiting, fever. You remember the signs, of course, I think. So the pyelonephritis, if a patient comes with pyelonephritis, we could also make ambulant therapy. It means we should not take the patient at the hospital in charge. We could start the therapy, patient could go home and come for 2-3 days for a control. Also, we could take the patient at the hospital, and it means the hospital therapy or the hospitalization. So for ambulant therapy, if the patient is in conserved general condition, if they have no confusion, they can drink, they can eat, we can also make this ambulant therapy. So the therapy is based of this antibiotics, which called ciprofloxacin. We give 2 times 500 milligrams 7 days. The alternative is TMP, SMX. So it means the ambulant therapy for pyelonephritis for non-complicated, the normal patient, the conservative patient, is like the cystitis therapy, if you remember. But if the patient are hospitalized, we give ceftriaxone 2 grams intravenous 7 days. So every day we give 2 grams ceftriaxone. But the alternative could also be meropenem, so 31 milligram per kilogram intravenous for 7 days, plus symptomatic therapy. Let me make a resume. I want to come back. Okay. I think it's not possible. So it's blocked. Yeah. So I hope that the therapy of urinary tract infection is clear. We have the upper infection, pyelonephritis, that we could do the therapy ambulant or at the hospital. The lower urinary tract infection, the cystitis or urethritis. Cystitis the non-complicated cystitis and complicated. The non-complicated, we could start directly the therapy and then culture to adapt our antibiotics. The complicated, directly we have to do the urine analysis and culture. And the urethritis, we have ceftriaxone intramuscular 500 milligram plus 7 days doxycycline, or intravenous ceftriaxone 1 gram plus 7 days doxycycline. Now let's see the complication. If we don't treat a urinary tract infection, what could happen? Of course, pyelonephritis, I think that is right now clear. So there is the ascension of the bacteria from cystitis, from bladder to the kidney. Peripheric abscess, it is in kidney always. Urosepsis or emphysematous pyelonephritis. So it means that the kidney, the evacuations part of the kidney, due to the infection, they're going to be dilated, and it could be a chronic problem. In male individuals, it could be urethral stricture or epididymitis, the infection of testicle, prostatitis, inflammation of the prostate, or orchitis, inflammation of orgy from testicle. Unfortunately, as I said, woman by woman, it is also complicated because of the baby. So in pregnancy women, unfortunately, the urine infection could increase risk of preterm labor and birth, hypertension and preeclampsias, and it could also cause the chorioamnionitis, the infection of the amnios. The last part, the prevention of this infection, we have to increase the fluid intake, timely bladder voiding, post-coital voiding, and adequate genital hygiene. This is based also at clean intermittent catheterization, and the other prophylaxis is indicated for recurrent urinary tract infection, like chemoprophylaxis. Sometimes we give medicines or medicaments for patients to protect this patient from a future infection. Now, before to see the clinical cases, if there is any question, you feel free, please talk in microphone, and I'm here to see together with you or to find an adequate answer for a question. Any question?
Hello, sir. Can you hear me?
Sorry?
Hello? I have a question, sir.
Yes, please.
Can you hear me? Sir, if we have a patient and he complains from some itching during urination, what should we be suspected for if we have no other complaint? It's just complaining that while I'm urinating, I have some itching in my urethra.
Yes.
What
Sorry, excuse me, I didn't get the last part of your question. So if a patient can comply because of urinary issues, so
he is suffering from itching during urination. He
yes,
complains that when I'm urinating, I feel like I have some itching, not very much that it bothers me, just a little bit. What should we be suspected for?
okay, great. We have to first of all ask we have to see if the patient had sexual contact. Because if the patient say that has only itchy and suffering during urinating from this itchy, and said that last week or some days ago had a sexual contact, and at the same time before the urinating has some discharge like white or milky discharge, it could be urethritis or infection of ureter. In this case, we can also start directly the therapy, as I said, with doxycycline. And we have to adapt the therapy after urine analysis or the STD screening, sexual transmitted disease screening, which could show us the infection from 5 different bacteria, chlamydia, gonorrhea, these 5 bacteria. But if they say that they had no sexual contact, or they had sexual contact which was protected or with the same partner, it could be considered like a cystitis, like acute cystitis. And we have to, by men, we have to always start the therapy at the same time urine culture, and we have to adjust our therapy. I hope that I gave you the answer.
Yes, thank you, sir. Thank you.
You're welcome.
Thank you so much, Dr. Zahir. We have another student, Dr. Najma. Please ask your question. Unmute your mic.
Hello to everyone.
Thank you.
Hello, sir. First of all, thank you so much for the amazing lecture. Sir, I have a question that if a patient has a UTI and also he has a prostatitis, on that time, which therapy treatment we use it? Again, it's antibiotics, ceftriaxone, or doxycycline, or we changed that?
So if the patient has a non-prostatitis, the patient had prostatitis and had the therapy and count for this infection. For that, we have the special therapy for the inflammation of the prostate, and also at the same time, antibiotics for the urinary infection. The antibiotics for the urinary infection is like complicated urocystitis therapy that we saw together in the chapter. We could start with ceftriaxone intramuscular or intravenous plus doxycycline 7 days, 200 milligram, 2 times a day. And after we fix the therapy, we adapt the therapy depending on the laboratory finding. And for prostatics, we have several medicines, several therapy that it could be maybe part of some other colleagues to solve with you. Some of them they're anti-inflammatory, and we have several therapy for that. But if a patient comes with urinary infection which is caused by prostatitis, the therapy is not an emergency. We have to refer the patient to urolog or urologist.
Okay, thank you, sir.
You're welcome.
Dr. Adila, do you have any question? Okay, Dr. Zahir. Okay, Dr. Adila, please share your question. Okay, thank you, Dr. Zahir. I think we don't have further question. You can share the clinical case now.
Very well. So let's see. The first case is, okay, before that we see the clinical cases. Now, how we manage your answer, maybe you can answer in chat or you use your microphone, no problem.
They will answer in the comment box.
Okay, great. That's great. So the first case, we have a 25-year-old man with fever and back pain since 5 hours. So it's an emergency case. And the patient said that he unfortunately is suffering since 2 days from dysuria, urinary urgency. What could be your diagnosis? Since 5 hours, back pain and fever. Since 2 days, so since 2 days, dysuria and urinary urgency, but the developing of the symptoms since 5 hours is also fever. Let's check the answers. So I have 3 questions. What could be your diagnosis and what kind of a labor or laboratory searching you're going to offer and which treatment are you're going to propose? So let's analyze together. First, it is a 25 years man. So what can we suggest? Is it complicated infection or uncomplicated infection? You can write maybe in chat. Great, perfect. That's right. So this is the complicated infection and the patient is in your clinic or in your hospital. What are you going to do? Are you going to take blood test or urine? And why? Roya Khan and Ali, or and Ali, and sorry, Roya Khan and Ali. Okay, so listen. Great, yeah, urine culture, urine analysis. Okay, is it the first part urine or the middle or the last part of urine? Urine examination, that's correct, that's right. Mid, okay, that's great. And yeah, great. What could be your therapy purpose? How we can start the therapy? This is the last part of this first clinical case. Okay, antibiotics. Okay, so that is correct. And okay, so I see some colleagues, they wrote ciprofloxacin, nitrofurantoin, painkiller, amoxicillin, yeah. Okay, great. But so here you said that it is a complicated infection. So I said when it's complicated, we start directly with ciprofloxacin, 500 milligram, great, yeah. Okay. Yeah. I think I have a better idea. Let's do like this. Okay, we go forward for the second case, and then I'm going to do maybe with whiteboard a resume of the therapy, because with resume it's going to be also easy, and you can also remember for always. Perfect. So the second case, this is a 30-year-old pregnant woman with urinary infection. The question is, how do you define this infection? The second case, can anybody answer, please? I think. So here is the second question, or the second case. This is a 30-year-old pregnant woman with urinary infection. The question is, how do you define this infection? So the issue is that first, this question, the answer is here in definition, as we saw. So I think it was at the next page. So a woman, a pregnant woman come with urinary infection, it is always complicated. And the second question, so for complicated in pregnancy, we have to do the urine culture and also the pregnancy test. I hope that my technical team is hearing me. I want to use the whiteboard. Let's check. Yes. So, I want to just end this topic, and I do a whiteboard. Can you please let me see if I can use my whiteboard?
Hello, Dr. Zahir. You can use the whiteboard.
Okay, but it's written in German, nur der Haus. Only you can let me to use my whiteboard, unfortunately. Let me check here. Yeah. Yes, it's okay. Thank you. So To make a resume of the therapy, as I said, we have 2 kidneys. This is the urinary system. Here we have pyelonephritis, and here we have cystitis. And urethritis. The therapy of cystitis first, as I said, it is easy. We give NIT. When I write NIT, it means nitrofurantoin. So we gave like 100 milligram 2 times a day for 7 days. Our alternative is monoreal 3 gram only once. Okay, I hope right now it's easy to remember. Plus, we give also the symptomatic therapy like painkiller, paracetamol, dipyrone, many painkillers that we have, or sometimes ibuprofen also help. And at the same time, we have to say that we have to motivate the patient to drink a lot of water and wash genital area. The urethritis, as I said, we give ceftriaxone. When the patient comes with sign of urethritis, we give ceftriaxone. We can also give IM 500 milligram or intravenous 1 gram plus doxycycline 200 milligram for 7 days. Of course, we have to adapt the therapy after the labor finding. And so the complicated pyelonephritis therapy, it is, I want to write A and B like ambulant therapy. That means we are not taking patient at the hospital in charge. We give ciprofloxacin. We give cipro 2 times 500 milligram for 7 days. If we are taking the patient in charge at the hospital, we gave ceftriaxone